Audio Jungle.
Hello, welcome to Heartbeats from Lifelong Learning and our series on hyperlipidemia and atherosclerotic cardiovascular disease, or ASCVD. This program is made possible by an education grant from Novartis. However, the content has been created and directed by a volunteer planning committee independent of the grantor. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association or the American Stroke Association, and these materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA or ASA. The AHA or ASA does not endorse any product or device. In this episode, you'll learn about elevated lipoprotein A, or Lp(a), which is increasingly recognized as a significant independent risk enhancer of cardiovascular disease. This course explores the evolving landscape of Lp(a) in clinical practice, emphasizing the importance of Lp(a) testing in comprehensive cardiovascular risk assessment. The safety and efficacy of current and emerging lipid-lowering therapies with a focus on novel agents targeting Lp(a) reduction will be examined. My name is Dinesh Kalra, and I'm Professor of Medicine and Chief of Cardiology at the University of Louisville School of Medicine in Louisville, Kentucky. I'm the Director of the Lipid Clinic, and I'm a multimodality imaging cardiologist with a special interest in patients with dyslipidemias and those who are at high risk of developing atherosclerotic plaque. And my research involves ways to reduce that risk by applying novel therapies and plaque imaging with CT to guide therapy. I also serve as the governor of the Kentucky chapter of the American College of Cardiology and hold an endowed chair in cardiovascular innovations at the University of Louisville, and I'm the president-elect of the National Lipid Association. In my clinical practice, I take care of many patients with lipid disorders and ASCVD, including those with high Lp(a) levels, and advise them on ways to reduce their risk. All right, with that, we'll get started. So just a brief background on what is Lp(a). This has been covered in detail in some of the other talks, but I think it's important to set the stage as to what we're discussing and talking about. The Lp(a) particle is a lipoprotein that circulates in the plasma. And Lp(a) is made up of two components. It has an LDL-C-like component, so low-density lipoprotein component, which has inherently on it an ApoB100 molecule, as well as a second moiety that is not found in LDL. And that second moiety is an apolipoprotein. And as you can imagine, because it is an apolipoprotein that is a part of lipoprotein a, the name of this apolipoprotein is apolipoprotein A. These two molecules, the ApoA moiety and the LDL-C particle, are bound together by a disulfide bond. ApoA contains many kringles. It is a protein, and it has amino acids in groups of 80 or 90 amino acids that are bound together in the form of a kringle structure, which resembles like a Danish pastry. That's the name kringle for Danish pastry. And it has many such kringles. Some of these kringles are, for example, kringle 4, 1 through 10, and kringle 5. Now, what is unique about ApoA is the kringle 4, type 2, domain 2, can have multiple units, multiple repeats, and those repeats vary from anywhere from 1 to up to 50. And that's what determines the size of the ApoA lipoprotein. and that's what determines the plasma concentration. In fact, there's an inverse relationship between the two. So a smaller Kringle 4-2 repeat leads to a higher plasma level of Lp little a. And we'll talk about why that's important. Now, all of you are probably aware by now that Lp little a is an independent and causal risk factor for atherosclerotic cardiovascular disease. And it's quite common. 20% of the world's population has elevated levels of Lp little a, which means 1.4 billion people have high levels. In the United States, that translates to about 65 million people. Now, 90% of the Lp little a levels are determined genetically. So the LPA gene is the single most important determinant of how high someone's Lp little a serum levels are going to be. That means the levels are not affected much by diet or the environment. Lp little a is very pathogenic in terms of causing accelerated atherosclerosis. If you take one molecule of Lp little a and compare its atherogenic potential to one molecule of LDL, the Lp little a molecule is 6 times more atherogenic. So clearly, this is an important risk marker in our patients, and there's been a lot of interest as to what to do about this, how to reduce levels of this. Now, prior studies over the past decade have shown the importance of this, not just in ASCVD, but in other conditions also. So this is data from one such study. This is called the Copenhagen Heart Study, which showed that the Lp little a increased the risk of atherosclerotic cardiovascular disease, but also for calcific aortic valve stenosis, as well as for mortality, both cardiovascular mortality and all-cause mortality. You'll see the hazard ratios here shown next to every condition. The one in orange shows you the hazard ratio if the Lp little a is more than 90th percentile of the population for that population. And the one in red shows you the hazard ratio and the Lp little a levels are even higher, more than 99th percentile of the population. And so, for example, you will see that the hazard ratio for developing calcific aortic valve stenosis is 2.9 when your Lp little a levels are more than 300 nanomoles per liter. And for all-cause mortality, the hazard ratio is 1.2 when the levels exceed 125 nanomoles per liter. Now, why is Lp little a so pathogenic? Much more than LDL, as I said earlier. Well, that's because it has several features that make it not just pro-atherosclerotic, but it's also pro-thrombotic and pro-inflammatory. Pro-thrombotic because that Kringle structure that I described earlier is homologous to another protein in the blood called plasminogen. And because this competes, Lp little a's ApoA competes with plasminogen, it turns out that it can cause increased thrombosis by reducing the activation of plasminogen and increasing platelet responsiveness and many other mechanisms. It's also pro-inflammatory. I showed earlier on the structure that it carries oxidized phospholipids, and these oxidized phospholipids can enhance inflammation and cause endothelial damage and cause recruitment of cytokines that increases its inflammatory nature. And the pro-atherogenic nature is because of the LDL-C content, as well as its ability to cause smooth muscle cell proliferation and foam cell formation. Now, the guidelines have recognized that high Lp little a levels are a risk enhancer. If you look at the bottom left, the guidelines on cholesterol treatment from 2018 stated that if the Lp little a levels were in excess of 125 nanomoles per liter, which is the preferred way of expressing the level rather than in milligrams per deciliter, but that translates roughly to about 50 milligrams per deciliter, that could be used as a risk-enhancing factor to consider statin therapy in your patients if they did not otherwise meet criteria. So if they were at low risk or borderline risk, then the presence of an Lp little a in excess of 125 nanomoles per liter would push them up or upgrade their risk so then you could initiate statin therapy. And for the patients that were already on statin therapy based on these guidelines, the presence of a high Lp(a) meant that you would have to do much more. You would control the risk factors even more aggressively, and you would use high intensity statin therapy and try to get the overall risk of the patient as low as you could to reduce the overall risk. Now, in the United States, as I mentioned, the ACC/AHA guidelines have used Lp(a) as a risk enhancer to start treatment, but in terms of screening, it is not yet recommended for everybody at the moment, although the new guidelines may change that. But at the moment, the 2018 guidelines instruct us to check Lp(a) levels if a patient has a personal history of premature atherosclerotic cardiovascular disease, or there's a family member, a first-degree relative with premature ASCVD. But you'll notice here on this chart, there are multiple other international guidelines that recommend much broader screening, given the data I've shown you that Lp(a) is truly an important risk marker and causal factor in ASCVD, so perhaps we should be screening more widely. In fact, the National Lipid Association indicates in its latest update and guideline that Lp(a) should be measured at least once in all adults and selectively in high-risk children. For example, if a child has a parent who has a known high Lp(a), that would be a reason to measure it in a child. But otherwise, for everybody over the age of 18, the National Lipid Association recommends measuring it. So does the European Society of Cardiology. In fact, the latest update from the ESC that was just released last week states that patients whose Lp(a) levels are more than 50 milligrams per deciliter are classified at high risk. And they use an equivalence of 105 nanomoles per liter rather than the 125 that many other societies have recommended. So there's ways of looking at the risk of patients. If the levels are less than 75 nanomoles per liter, which is 80% of the population is going to have a level below 75 nanomoles per liter. Those patients are considered to be at lower risk. Then there's going to be patients in between who are going to be intermediate risk. And then there's going to be patients that fall in the top 20 percentile. So variably between either 125 nanomoles per liter or 105 nanomoles per liter. And those patients are considered high risk, and these people should be treated more intensively. Now, we all know from the cholesterol treatment trialist data that when you reduce LDL cholesterol by 1 millimole per liter or 38 milligrams per deciliter, you get about a 20-22% reduction in cardiovascular events. For Lp(a), that amount of reduction needs to be much larger. One generally needs to see a 66 milligrams per deciliter reduction in Lp(a) to get the same benefit as you do by reducing LDL by 38 milligrams per deciliter. As I mentioned earlier, diet and environmental factors don't affect Lp(a) much. What about drugs? So statins, in fact, may either have a neutral effect on lowering Lp(a) or paradoxically may actually increase Lp(a). That doesn't mean one should stop statin therapy because the benefit persists despite that small increase in Lp(a). But it's just something to bear in mind. If somebody's checking serial Lp(a) levels, for example, the statins may be accounting for a small bump in Lp(a) levels if you do happen to check them again. Most of the other drugs we use for lipid lowering on a daily basis only cause small reductions in Lp(a). Niacin, for example, causes a slightly larger reduction, but it's not used clinically because of lack of cardiovascular benefits. But the ones that I want to highlight that are used often for our lipid patients are drugs such as the PCSK9 inhibitors, and they cause about a 20 to 27% reduction in Lp(a). None of these drugs is specifically approved for lowering Lp(a) levels today. As of today, the only kind of therapy that is approved to lower Lp(a) levels is apheresis. So if your patient has pre-existing cardiovascular disease and a high Lp(a) level, then that patient could have an FDA indication for receiving apheresis. Although it is not used very commonly, that remains an option. There are many drugs in development, which I'm going to talk about shortly, that do reduce Lp(a). But one of the drugs is obicetrapib, which incidentally, on a happy note, not just reduces ApoB, but also reduces Lp(a) substantially in one study by up to 54%. Now, when we look at PCSK9 monoclonal antibodies, you'll recall that these trials tested whether or not addition on top of a statin would result in a further reduction in LDL-C and a further reduction in MACE events. That was the design of these very large trials, both the Fourier trial using evolocumab and the Odyssey outcomes trial using alirocumab. But in a post-hoc analysis, what the investigators wanted to see was there a differential effect of the drug on cardiovascular outcomes in patients in these trials who had Lp(a) levels that were below the median or above the median. And what they noted was that there was a larger benefit effect size with the PCSK9 agents in patients who had high Lp(a) levels, higher than the median, thereby suggesting, hypothesis generating, that perhaps not just the LDL reduction, but also the effect of these monoclonal antibodies on Lp(a) reduction was yielding some sort of additional benefit in terms of reduction of cardiovascular events. So that remains a hypothesis with these drugs. Now, specifically, and to the main topic of our talk today, what are the drugs that are in the pipeline that are looking at Lp(a) reduction, and which ones are looking at cardiovascular outcomes? I've listed here 6 drugs that are in the pipeline. I'll go over most of these one by one. The first one is pelacarsen, which is an antisense oligonucleotide. The second one is olpasiran, which is a small interfering RNA. And for those of you listening in, the way to remember this is the mnemonic. The serans, the ones that end in RAN, are typically small interfering RNAs, and the arsins are always antisense oligonucleotides. The next drug is lepodisiran, zerlasiran. There's an oral drug called muvalaplin that is not RNA interference therapy. It is not a nucleic acid therapy, but it's actually a different way, and I'll explain that to you. And then there's a few others. There's an oral compound that is being developed by Merck called HRS 5346, obicetrapib, as I mentioned, which is a CETP inhibitor. And then there's gene therapies, base editing with CRISPR-Cas that is very early in its development phase. But note the amount of reduction of Lp(a) with these drugs. So pelacarsen, it's about 80%. Most of these drugs are 80% and higher. Olpasiran, up to 100% reduction. So you can really expect to see some reduction in cardiovascular outcomes if our hypothesis turns out to be true, that pharmacologically reducing Lp(a) levels can impact adverse outcomes. Now, how do these drugs work? What is the difference between an antisense oligonucleotide shown on the left and a small interfering RNA molecule? ASOs are single-stranded DNAs. siRNAs, on the other hand, are double-stranded RNA molecules. They typically have about 20 oligonucleotides, and ASOs will get into the nucleus of the cell and bind to the messenger RNA in the nucleus. And then there's an intrinsic nuclear enzyme named RNase H that breaks down this complex. So ASOs will lead to the destruction of the messenger, preventing the formation of the protein. And so there will not be any translation of the Lp(a) gene into the protein product. siRNAs do not act in the nucleus, they act in the cytoplasm. And as I mentioned, they have two strands. One is a sense strand and an antisense strand. The sense strand or the passenger strand dissociates, and the action is carried out by the antisense strand. The antisense strand binds to the mRNA in the cytoplasm, and then it gets broken down by a complex known as the RNA interfering silencing complex, RISC complex. And that leads to lack of translation of the protein again. Now, let's go over these drugs one by one. The first one is pelacarsen. This is a study from Sam Semikas that was published in 2021 in the New England Journal. This was a dose-ranging study looking at various doses of pelacarsen that were administered subcutaneously every 1 week to every 4 weeks. And because these are antisense oligonucleotides, they can be injected subcutaneously and be delivered to the liver because of a moiety that they are bound to called GalNAc, which is N-acetyl-galactosamine that renders them specifically hepatotropic. So you need smaller doses of these drugs, and they can survive in the body for up to 4 weeks, these drugs, because of these chemical modifications to these oligonucleotides, and act specifically on the liver without any off-target effects. So that is the beauty of this nuclear engineering that has allowed these drugs to come into clinical trials. And you'll see that you start noticing lowering of Lp(a) within the first month, within the 4 weeks, and then you get a maximal effect by about 16 weeks. And so the 20 milligrams subcutaneously every week dose, for example, led to an 80% reduction in Lp(a) levels, and 98% of patients were able to achieve a level less than 125 nanomoles per liter. Not only did it reduce Lp(a), it also reduced oxidized phospholipids, those pro-inflammatory components of this molecule, both on the ApoA moiety as well as on apolipoprotein B moiety. And it reduced ApoB levels by 18% and LDL cholesterol levels by about 20%. So that has now led to a phase 3 outcomes trial that has been fully enrolled, and this is called the LPA Horizon trial. This was run by Novartis. There's 8,000 patients in this trial, double-blind, placebo-controlled. Inclusion criteria included Lp(a) levels of more than 70 milligrams per deciliter, so roughly about 175 nanomoles per liter. And all of these patients needed to have pre-existing cardiovascular disease. So they needed to have either a prior MI or ischemic stroke or PAD with an ABI of less than 0.85. And the primary endpoint is a combination endpoint. What we typically see in these large trials is a MACE-4 endpoint, so cardiovascular death or non-fatal MI or non-fatal ischemic stroke or urgent coronary revascularization, whichever comes first. The readout has been delayed a little bit because of slower number of events than initially thought. This is an event-driven trial, anticipating to get up to 993 events to have adequate power to show a benefit, and we expect results in the first quarter of 2026. I should also mention that the same drug is also being tested to see if it can slow the progression of aortic stenosis in another trial called Frontiers, CAVS, calcific aortic valve stenosis. So in patients who are 50 to 80 years old who have mild to moderate aortic stenosis, administration of this drug will be evaluated to see if it can reduce the echo peak velocities as well as aortic valve calcium scores by CT. The next drug is olpasiran, which is being developed by Amgen, and in the first dose-ranging study called Ocean-A-Dose that was published in 2022, you can see it had very impressive reductions in Lp(a) levels up to about 100%. And the waterfall plot show you that with escalating doses of the drug being used, you would get a quicker reduction in Lp(a), and a much larger reduction in Lp(a). So, for example, the 225 milligrams dose taken every 12 weeks or 24 weeks would lead to up to 100% reduction in Lp(a) levels. Very powerful, and you'll notice it can be dosed less frequently. Now, every 12 weeks or every 24 weeks instead of pelacarsen, which is being dosed every 4 weeks. Now, even after the drug had been stopped administration, for example, here, there was persistence in the effect even at 1 year. So I mentioned the 100% reduction in Lp(a) levels at week about 36 or 48. But once the drug is stopped, even after that, up to a year, you do get about a 50% reduction in persistence of effect. Now, this is also being looked at in an outcomes trial called TIMI 75 or Ocean A Outcomes. It's again about 7,000 patients in this trial. The inclusion criterion includes patients with Lp(a) more than 200 nanomoles per liter and either type 1 MI or they've had coronary revascularization plus one additional risk factor. You'll note here that peripheral arterial disease and stroke are not sole inclusion criteria. They have to be in combination with some sort of revascularization. So there's little nuance of difference there. And these patients are assigned to 150 milligrams of olpasiran every 12 weeks or placebo. And the primary outcome is not MACE-4, but MACE-3. And this includes coronary heart disease death, MI, urgent revascularization, whichever occurs first. And we expect this to read out in fourth quarter of next year, so 2026. The next drug is lepodisiran. Lepodisiran is being developed by Eli Lilly and in the dose-ranging trial called Alpaca. This is the structure of the siRNA. You've got a self-sense strand and an antisense strand, as I explained, that are bound to these sugar moieties called GalNAc that makes them hepatotropic. And this is a 22 oligomer that binds to and degrades the mRNA for Lp(a). In the dose-ranging study published just earlier this year, several doses were tested, and at the highest dose, which is 400 milligrams, that could be dosed every 24 weeks, you notice that you got a 94% reduction in Lp(a) levels. These are more details about the trial. It had about 320 subjects. The doses studied in this were 16 milligrams or 96 milligrams or 400 milligrams versus placebo. And your average median Lp level at baseline was about 254 nanomoles per liter. And for the time average reduction for a single dose of 400 milligrams from day 60 to 180 was 94%. All of these drugs have excellent safety results in these smaller trials. Though, you have some incidents of injection site reactions, which is anywhere from 8 to 11% for this drug, for example. That's fairly typical. These are quite minor. One of the signals that was not seen in some of the other trials that was noted here was the threefold rise in ALT or AST occurred in about 2 to 5% of patients. So that's something we'll have to keep an eye out during the outcomes trial. But again, no other major safety signals on this and very powerful lowering effects. The outcomes trial here is called the CLAIM trial, very large trial, 12,500 patients that is ongoing. It's expected to last 5.5 years with a readout in 2019. Inclusion criterion is a criteria Lp(a) more than 175. And again, either established ASCVD or, very interestingly, in a little departure from the construction of the other trials, this trial allows high-risk primary prevention patients. The other trials do not. They were all secondary prevention trials. This trial can have patients with silent subclinical CAD, for example, detected on CT or angiography that is not led to a prior event or carotid stenosis on an ultrasound or CT, or a combination of risk factors that puts people at high risk or familial hypercholesterolemia. So high-risk primary prevention patients are allowed, and the primary endpoint is going to be MACE-4. Another drug in the siRNA category is zerlasiran, being developed by Silent Therapeutics. And the phase 2b data were presented last year. This was, again, a small trial, 200 patients, mean age of 64. Median LPA was 213 nanomoles per liter, and they used several doses at 16 or 24 weeks, either 300 milligrams or 450 milligrams. And you'll notice that with the 450 milligrams given every 6 months, one achieved an 86% reduction in serum Lp(a) levels. And also, there was a reduction in ApoB of 15% and a 25% reduction in LDL cholesterol levels. These are the waterfall plots showing that the majority of patients had quite a robust reduction of in excess of 90%. And when you gave two 450 milligram doses at 0 months and 6 months, when you check the levels of Lp(a) in the serum at 60 weeks, there was still a persistent 50% reduction in these levels. Next drug is going to be muvalaplin, which is an oral drug. So very different from the prior drugs and very interesting concept. Muvalaplin prevents the formation of an intact Lp(a). It prevents the binding of the ApoA to ApoB100. And that occurs initially by preventing the non-covalent bonds that exist at the Kringle 4, 7, and 8 positions. And so this is a very interesting disruptor of the assembly of the formation of a mature Lp(a) particle. In the dose-ranging study called Kraken, that is led by Eli Lilly, these are, again, patients with elevated Lp(a) levels. Small trial, about 200 patients done across the world in 43 sites. You'll notice that the highest dose of muvalaplin used, 240 milligrams, led to an 86% reduction in Lp(a). What are these two assays? Well, the first type of conventional assay is the one that measures just the ApoA moiety itself. But you will notice that because this drug inhibits the binding of the ApoA moiety to the ApoB100 and prevention of formation of the full molecule, a better assay would be that test for the intact Lp(a) levels. So when you use that particular specific kind of assay to look for intact Lp(a), you're able to demonstrate a much greater reduction in the lowering. And so that's what was shown in this trial. And 97% of patients achieved an Lp(a) level of less than 125 nanomoles per liter. There was also additional reduction in ApoB levels of about 16%, as we saw in the prior trial. There was a small, non-significant reduction in high-sensitivity CRP, but importantly, there was a substantial reduction in the oxidized phospholipid content, which may be important for outcomes. This drug does not have an outcomes trial going on at the moment. I've put here a summary for you of which drugs are being tested in trials, what are the doses, what is the expected reduction in Lp(a) being seen, and what is the readout. So very exciting as to the number of drugs that are being studied in this space. And we likely will have data very soon next year telling us if there's a reduction in cardiovascular outcomes. To sort of summarize, Lp(a) levels are seen in 20 to 25% of the world's population and are causally related to a variable, but at least a 1.45-fold increase in the risk of coronary artery disease, stroke, peripheral arterial disease, heart failure, and aortic stenosis. Several lines of indirect evidence suggest that lower Lp(a) levels may be associated with lower levels of MACE. Many new RNA therapeutics and other agents are being tested in patients with high Lp(a) who already have ASCVD or are at high risk, and also in aortic stenosis. And the long-term efficacy and safety of these approaches will become clearer over the next 5 years. Just to give you some of my perspective on this, I think this is a field that has moved so quickly from the discovery of the molecule and from Mendelian studies and genome-wide association studies that established its correlation and then causality with not just ASCVD, but with aortic stenosis. And now to the not just introduction and dose ranging studies of nucleic acid therapies, but outcomes trials that have been completed. This is a tremendously fast pace of progress. And it will be really exciting to see if we can get these levels down in our patients. I think that's already been demonstrated. But then the more crucial link, does reducing LP little a in our patients who have these high levels, does it alter their risk of future cardiovascular events? I think that's going to be very exciting. With the new guidelines on testing LP little a that will likely be released soon in the new cholesterol guidelines, hopefully there will be some talk about broader screening. I do cascade screening in my clinic on all patients who have a relative who's had demonstrated high LP little a levels, aside from patients who have premature atherosclerotic cardiovascular disease. And I do screening in all adults in general, as per the NLA guidelines. But we have so many patients that have high LP levels, and at the moment we're just giving them high dose statins and perhaps a PCSK9 inhibitor if they need it. But this is so exciting that once these drugs show us whether or not there's reduction in outcomes, we'll be able to really make an impact on the cardiovascular outcomes for these patients. Thank you all for participating in this Heartbeats from Lifelong Learning. To get additional information and to claim credit, please visit learn.heart.org. Thank you.